Today we will talk about the cervical tumors. So cervix is the lower and narrow part of the uterus that include the supravaginal part and the vaginal part. And the cervix include the internal os and the external os. And in between the internal and external os is the endocervical canal. And the cervix is divided into two main parts. One is the endocervix, which is lined by the columnar epithelium, and the ectocervix, which is lined by the squamous epithelium. So now let's talk about the benign condition, in which the first one is the cervical ectropion. Ectropion is a condition in which the normal squamous epithelium of the ectocervix is replaced by the columnar epithelium. So cervical ectropion is defined as the presence of the columnar epithelium on the ectocervix, and it is associated with excessive vaginal discharge that is non-purulent in nature. And the patient of cervical ectropion may present with the postcoital bleed, that is the bleeding after the intercourse, because the fine blood vessels within the columnar epithelium are easily traumatized, and it is a normal phenomenon that is associated with a high level of estrogen that occur during the ovulatory phase of the menstrual cycle, during pregnancy, and the women who use oral contraceptive pills. So, and the treatment of cervical ectropion is discontinue the all contraceptive pills, and similarly we also do the ablation with the help of a thermal probe, and the ablation destroy the epithelium up to a depth of around 3 to 4 mm. So cervical ectropion is the presence of the columnar epithelium on the ectocervix, and it is associated with excessive vaginal discharge, and it occurs during the ovulatory phase, during pregnancy, and women who use all contraceptive pills. And the treatment include discontinue all contraceptive pills and the ablation of the epithelium. Second one is the Nebotian cyst. Nebotian cyst is also a benign cervical condition, and it is a mucus retention cyst that occur on the surface of the ectocervix. And the Nebotian cyst occur because of the blockage of the endocervical mucosal gland due to the squamous metaplasia that occur within the transformation zone of the ectocervix. So in Nebotian cyst, there is a blockage of the mucus gland occurred by the squamous metaplasia, and it involves the transformation zone of the active cervix. And the Nebotian cyst usually appear as a small white and pimple-like elevation that usually occur singly, but can also occur in groups. And they are common in women of reproductive age, and they do not require any specific treatment. Next is the cervical intraepithelial neoplasia. Neoplasia means the abnormal growth of the cell that involve only the epithelium of the cervix, and the basement membrane is intact. So CIN is defined as the cervical dysplasia with intact basement membrane, and it is regarded as a precursor lesion for the carcinoma of the cervix. And the CIN will commonly involve the transformation zone of the cervix, and it is the CIN is a histological diagnosis, and it is associated with the following risk factor. So the common risk factor for CIN is persistent infection with a high risk human papilloma virus, that is human papilloma virus 16, 18, 31, 33, and 45. Similarly, the multiple sexual partners, early age at the past intercourse, chlamydia infection, immunosuppression, all of these are the risk factors for the CIN. So CIN is simply the cervical dysplasia with intact basement membrane. It is a precursor lesion for the carcinoma of cervix, and it involves the transformation zone, and it is a histological diagnosis. And the most common risk factor is persistent infection with the human papilloma virus. And the CIN is classified into the following three types. First one is the CIN1, which is a mild dysplasia that involves the lower one-third of the epithelium of the cervix. CIN2, which is a mild dysplasia and it involves the lower two-thirds of the epithelium. And CIN is the severe dysplasia that involves the full thickness of the epithelium. So CIN1 is a mild dysplasia, CIN2 is the moderate dysplasia, and CIN3 is the severe dysplasia that involves the full thickness of the epithelium. Next is the screening of the CIN. So CIN one can spontaneously regress in about 60% of the cases, and this patient can only be observed. And the CIN2 and 3 are less likely to regress, and therefore they require treatment. And the CIN2 and 3 can progress to the cervical cancer in about 20% of the cases if they are left untreated. So the first one in the screening is the cytology. So cervical cytology is the best initial screening test, and the cytology include either the liquid-based cytology or the Pap smear. And cervical cytology may be normal in about 95% of the women, and they require only follow-up. And there may be minor cytological abnormalities found. If there are minor cytological abnormalities on the screening test, then we do the high-risk human papilloma virus DNA test. And if there are high-grade cytological abnormalities, then we do colposcopy. So the initial screening test is the cytology, which is either liquid-based or the pap smear. Next, we do the high-risk human papilloma virus DNA testing, and this test has a high negative predictive value. Means that if this test is negative, then the risk of developing cervical cancer is very low. And this test is done when the initial screening test there shows minor cytological abnormalities. And if this test is negative, then we do only routine follow-up. And if this test is positive, then we do colposcopy. Third one is the colposcopy. Colposcopy is the detailed examination of the cervix to identify the CIN and the invasive carcinoma, and it is both diagnostic and therapeutic. And it involves the use of colposcope, which is a binocular operating microscope with a magnification power of 5 to 20 times, and it is done by a patient who show high-grade cytological abnormalities on the screening test, or a patient who have positive high-grade human papilloma virus DNA testing. And this test involves the application of acetic acid and the iodine, and areas of increased cell turnover, the CIN will appear white on the application of acetic acid, and on iodine the area of CIN will pale to turn brown. So colposcopy is used to identify the CIN and the invasive carcinoma, and it is both diagnostic and therapeutic. And it is done in a patient who have high-grade cytological abnormalities on the screening test, or who show the high-grade human papilloma virus DNA testing. And patient who have low-grade appearing CIN on colposcopy, they require only follow-up and 6 months with cytology. And a patient who have high-grade CIN, they require treatment. Next is the management and follow-up of a CIN patient. So the treatment options for CIN1 is follow-up in 6 months with colposcopy and repeated cytology, because in majority of the cases the CIN1 may regress spontaneously, whereas the CIN2 and 3 they require treatment, and the treatment include ablative modalities and the excisional modalities. First one is the ablative modalities. Ablative modalities involve the ablation of the epithelium showing neoplastic features in the transformation zone. And the ablative modalities include cryotherapy, laser vaporization, and the cold coagulation. And it can be done by CIN1, CIN2, and the CIN3. And ablative procedures are quick, they are cheap, and they are easy to learn. But the main disadvantage of these modalities are that there is no histology available for review. Second one is the excisional procedures. The excisional procedure include larger loop excision of the transformation zone, which is the most common excisional procedure. Other procedures include excision with the help of diathermy wire, carbon dioxide laser, and the cold knife conization. So larger loop excision of transformation zone is the definitive treatment for the high grade CIN, that is the CIN2 and CIN3, and it is safe and easy to perform and usually possible with local anesthesia. And the excisional margin obtained should be at least 7 millimeter deep. And the advantages of larger loop excision is this procedure is effective because 95% of the women will have negative cytology at around 6 months, and it also provides tissue pathological diagnosis, and it is a cost efficient procedure. But the disadvantages include increasing risk of second trimester miscarriages due to the large repeated excision of a cervix, and they also increase the risk of preterm delivery. And similarly, there may be incomplete excision of the lesion occur. And follow-up after the excisional and the ablative procedures include uh, follow-up is usually done in 6 months with cytology and the human papilloma virus DNA testing. And if the follow-up screening tests are positive, then we do colposcopy, and if they are negative, then we do routine screening within 3 years. Next is the current guidelines for the cervical cancer screening. First one is the American Cancer Society guidelines. According to these guidelines, the cervical cancer screening has decreased the incidence and the mortality of the cervical cancer. And the cervical cancer screening involves cytology, that is the pap smear or the liquid-based cytology, and the human papilloma virus DNA testing. And the screening age for the CINS, the screening age should be started at the age of 21, irrespective of the sexual activity. And the women who are less than 30 years of age, we do only pap test, and the pap smear should be repeated every 3 years. And human papilloma virus testing is not recommended, and it should only be done if there is abnormal pap smear. And the women who are more than 30 years of age, we do the pap smear every 3 years. We do the pap smear with the human papilloma virus testing every 5 years, and the women who are vaccinated against the human papilloma virus still follow the same guidelines, and the women of any age should not be screened every year by any of the screening method. So the screening methods include the pap smear or the liquid-based cytology and the human papilloma virus testing, and the screening should be started at the age of 21 years. And women that are less than 30 years of age, we do only pap test. It should be repeated every 3 years, and a human papilloma virus testing is only done if there is abnormal pap smear. And the women who are more than 30 years of age, the PEP test should be repeated every 3 years, or the PEP test should be done along with the human papilloma virus testing after every 5 years. And next is when to stop the screening for the CIN. So the women who are more than 65 years of age, along with the inadequate prior screening, who had two consecutive core tests of Pap smear and human papilloma virus test negative in the past 10 years, and who have three negative consecutive Pap smear tests in the past 10 years. Along with there is no history of high-grade dysplasia, and there are no risk factors, that there are no history of smoking, no human papilloma virus-related diseases, no new sexual partner, and no history of immunosuppression, suppression, and there is no history of exposure to the diethyl cell bestrol. And the women who had done subtotal hysterectomy, in which the cervix is intact, they also require the same guideline for the screening. And the women who had undergone total hysterectomy, in which cervix is also removed, they require no screening for CIN. Now let's talk about the Pap smear. So Pap smear is a cytological screening test, and it is done for the detection of the pre-malignant lesion of the cervix. And the recommended age for the Pap smear is 21 years. So this test should be started at the age of 21 years, and it should be repeated every 3 years. And the Pap smear is done alone in women in between the 21 to 29 years of age, and the Pap smear should be done along with the human papilloma virus DNA testing in women more than 30 years of age, and it should be continued until the age of 65 years. And the technique for the pap smear is within the 24 hours of testing, avoid touching, menstruating, heavy sexual intercourse, and avoid using tampons. Similarly, place the patient in a lithotomy position, and then select an appropriate size cusp or speculum to retract both anterior and posterior vaginal wall and expose the cervix. Then obtain two samples from the cervix. First one is the ectocervical sample, that is obtained with the help of IR spatula by scraping the transformation zone. And the second sample is the endocervical sample, which is obtained with the help of cytobrush in non-pregnant women, and with the help of cotton tap applicator in the pregnant woman. And the smearing methods include two types. First one is a conventional method, and second one is a liquid-based cytology. In conventional method, the specimen obtained are smeared on a glass slide, and then we apply a preservative agent, that is ethyl alcohol, on it, and then examine the smear under microscope. Second one is the liquid-based cytology. In liquid-based cytology, the specimen obtained is rinsed into a preserving solution, that is ethyl alcohol, and then deposited on a slide as a thin layer of the process cell. Next is the interpretation of the pap smear. So for the interpretation of pap smear, we have a specific classification system, that is the Batista system. According to this system, the pap smear result shows two types of cellular abnormalities, that is either the squamous cell abnormalities or the glandular abnormalities. First one is the squamous cell abnormalities, that include atypical squamous cells, which include atypical squamous cells of unknown significance, and atypical squamous cells in which we cannot include the high-grade squamous intraepithelial lesion. Second one is the low-grade squamous intraepithelial lesion, which correspond to mild dysplasia, that is CIN1, and third one is the high-grade squamous intraepithelial lesions that include moderate dysplasia, which is CIN2, and the severe dysplasia, that is CIN3, and the atypical squamous cells of unknown significance. And fourth one is the squamous cell carcinoma. So the squamous cell abnormalities include atypical squamous cells, low-grade squamous intraepithelial lesions, high-grade squamous intraepithelial lesion, and the squamous cell carcinoma. Second one, cellular abnormalities found on the pap smear are the glandular cell abnormalities that include the atypical cells that are non-specific, and neoplastic atypical cells, adenocarcinoma in situ, and the adenocarcinoma, which is endocervical or endometrial in origin. Now we will talk about the cervical cancer. Cervical cancer is the second most common cancer in women worldwide after the breast cancer, and the cervical cancer arises from the squamous-columnar junction, which is the site where the columnar epithelium of the endocervix combined with the stratified squamous epithelium of the ectocervix. And the cervical cancer is a similar risk factors as that for the CIN, and the risk factors include infection with the human papilloma virus, multiple sexual partners, and early age at the time of intercourse, and immunosuppression and chlamydia infection. And the presentation of cervical cancer patient include postcoital bleed, intermenstrual bleed, postmenopausal bleed, and a picture that are suggestive of advanced disease include patient presenting with a history of heavy bleed vaginally, and there may be signs of ureteric obstruction. There may be a history of weight loss, or there may be bowel disturbances like history of constipation, etc. And there may be fistula formation occur, which occur in advanced disease. And the most common fistula is vesico-vaginal fistula, which is the abnormal communication between the vagina and the bladder. Uh, Next one is the type of the cervical cancer. So the types include squamous cell carcinoma, which is the most common type of the cervical cancer, account by about 70% of the cases. The other types include adenocarcinoma, clear cell carcinoma, sarcomas of the cervix, neuroendocrine tumor, and the glassy cell tumor. Next is the investigation done in case of the cervical cancer. So initially we do the colposcopy, which is the detailed examination of the cervix, and it is both diagnostic and therapeutic values. Second is the cervical biopsy. Cervical biopsy is important, and it is done to confirm the malignancy and also to identify the type of the tumor. Similarly, we also do MRI of the abdomen and pelvis, and the MRI is done to assess the local spread of the disease and also to identify where there is a lymph node involvement occur or not, and the cervical cancer is staged clinically. Next is the metastatic workup for cervical cancer. So we do full blood count. We also do urine electrolyte. We do liver function test in case of liver metastasis. We also do chest X-ray in case of uh, symptoms related to the chest or the lungs. Similarly, we also do intravenous pyelography, but it is not commonly done. Similarly, we also do CT chest, abdomen, and pelvis. We also do MRI abdomen and pelvis, and we also do cystoscopy in case of extension to the bladder, and similarly we also do sigmoidoscopy in case of rectal involvement. Next is the staging of the cervical cancer. So the cervical cancer is divided into four main stages. The stage one, the tumor or the cancer is confined to the cervix, and the stage one is divided into 1A and 1B. And 1A there is microscopic disease occur, and 1B there is macroscopic disease occur. And the 1A include A1 type and the A2 type. And A1, the maximum horizontal dimension is 7 mm, while the depth of invasion is 3 mm. While in A2, the depth of invasion is about 3 to 5 mm. And in 1B, there is macroscopic involvement of the cervix, which is then divided into two types, B1 and a B2 lesions. B1 lesion are less than 4 centimeter, B2 lesions are more than 4 centimeter. And stage 2, the tumor extend beyond the cervix, and stage 2 is then further divided into two types, stage 2A, in which the tumor involve the upper two-third of the vagina, and 2B, in which the tumor involve the parametrium. And the 5 year survival rate in stage 2 is 65%, while in stage 1 is 80%. And stage 3 is further divided into three main types, stage 3A, that involve the lower one-third of vagina, stage 3B, in which the tumor extend to the pelvic side wall, and if there is ureteric obstruction occur, it causes obstructive hydronephrosis, and the 5 year survival rate is 35%. And stage 4 is metastasis occur, and stage 4 is divided into stage 4A, in which there is extension into the bladder anteriorly, posteriorly into the rectum, and there may be extension beyond the two pelvis occur. And stage 4B, they involve the distant organ like liver and lungs. So, according to a Pego staging, the cervical cancer is divided into stage 1, in which the tumor is confined to the cervix, and there may be 1A, in which there is microscopic involvement of the cervix, 1B, in which there is macroscopic involvement of the cervix. And stage 2, the tumor extends beyond the cervix, and 2A tumor involve the upper two-third, and 2B, the tumor involve the parametrium. And stage 3, the tumor, stage 3A, the tumor involve the lower one-third of the vagina, 3B, the tumor involve the pelvic side wall, and stage 4 there is metastasis occur, and stage 4 there is involvement of bladder rectum occur, and stage 4B there is involvement of distant organ occur. Next is the treatment of the cervical cancer. So surgery is the mainstay of treatment for the carcinoma of the cervix, and the surgery we do for cervical cancer is known as routine hysterectomy. And this surgical procedure involves the removal of the cervix, uterus, spare cervical tissue, upper vagina, and also the removal of the pelvic lymph node. And the complication of this surgical procedure include bladder dysfunction, bleeding, increasing chances of infection in the ureteric fistula. Next is the treatment of the cervical cancer on the basis of staging. So in stage 1, we have A1, in which there is microscopic involvement of the cervix. We do wide local excision with the clear margins. And stage 1B, we do either routine hysterectomy or we do pelvic radiotherapy. Pelvic radiotherapy is done in patients who are too obese or unfit for the surgery. And from stage 2 to stage 4, we do radiotherapy. We do combined radio chemotherapy. Then the radiotherapy include external beam radiotherapy, a brachytherapy, which is internal radiotherapy that involve the insertion of selenium rods into the uterus. So it was all about the cervical cancer and its treatment.